With you a case of 73 years male, hypertensive, diabetic, but main issue was he presented with dyspnea for last about 7-8 days. And when we got this in RARV dilatation and hypokinetic RV, we immediately suspected the pulmonary embolism. We looked for the legs and there wasn't any swelling in the legs, but the TR was a moderate and there was a severe pulmonary artery hypertension based on a TR velocity of 3.4 meter per second. The GLS of RV was bad, so was the TAPSI indicating severe RV dysfunction. I think good idea to subscribe the channel. Now let's follow the story further. We got a venous compression ultrasound and the Doppler done, and which showed multiple thrombi and popliteal superficial femoral veins, and veins were non-compressible, giving a clear diagnosis of pulmonary embolism leading to PAH and RV dysfunction. How many of you guys are comfortable with M mode of a pulmonary valve? To tell you the truth, in our times we were trained on M mode onwards, and this is M mode of the pulmonary valve, and this is an EF slope. You see, this is an EF slope, and this EF slope is reduced. Normally it should be like this, and reduced EF slope indicates pulmonary artery hypertension. The very first thing to disappear is an A wave. First A wave disappears, then EF slope reduces, but when the right ventricular dysfunctions set in, the A wave appears again. So now there is a flat EF with A wave which indicates PAH and RV dysfunction. And then you have this systolic notch which indicates a severe pulmonary artery hypertension. Fantastic, isn't it? Now the same thing, now we can do it with an RVOT Doppler, and in RVOT Doppler we put the sample close to the pulmonary valve in a short axis view. You can actually see the click of the pulmonary valve. The very first thing you guys should do is that to do an accelerated time, and pulmonary acceleration time less than 80 is very specific for pulmonary artery hypertension, while less than 100 is indicative of pulmonary artery hypertension. Here we see something more than that. You see a systolic notch, and this is a mid-systolic notch, and in this patient we could see in fact two notches in the pulmonary artery. And what does this notch in the Doppler indicate? This indicates a pulmonary artery hypertension, and there have been a couple of studies. I could lay out one wonderful study which showed the notching pattern of the pulmonary artery Doppler or RVOT Doppler indicating severe pulmonary artery hypertension. It was also important to prognosticate these patients. Now, otherwise, normally I'm going to give you the mechanism how this notching happens, then you would understand. Please go through this video till the end so that I explain you which are the conditions where notching happens and why by an hemodynamic explanation. Normally the reflected, there are two waves, forward wave and reflected wave. Normally reflected wave falls somewhere here, not on the forward flow, and when there is a PAH, the waves are reflected, the arteries become stiff, the waves are refracted quickly, and in severer PAH, the waves are far more closer. So late systolic notch indicates moderate PAH, while early or a mid-systolic notch indicates a severer PAH. How should I know? Okay. Now I give you an example of a reflected and incidental or a forward wave in aorta. So let's take an example of aorta, and here you see this is incidental wave forward, and now this red one is a backward wave, the reflected wave. Both these waves actually submerge with each other to produce an anacrotic notch, which you guys know on the aortic Doppler or aortic pulse pressures. And once there is vasoconstriction, then there is this kind of phenomena which is produced. But when the arteries become stiff, okay, aorta becomes stiff, that is where the anacrotic notch appears early, and there is augmentation of the systolic wave, and this is because of augmented reflective wave and the reflected wave coming earlier because increase of the velocity, reflected velocity is increased because of a thickening or stiff aorta. Stiff aortas lead to a quicker return of the reflected waves, right? This was the reason for systolic hypertension in elderly people. Let us apply the same rule to our pulmonary artery hypertension. Look at again. Now I am going to show you two things. This is normal, and now let us say make the arteries narrow. Watch, the arteries are made narrow, and once you make the vasoconstriction of the arteries, this is a kind of reflected wave what you get, not a very prominent, not very accurate. Now then when you increase the stiffness of the artery, then there is increased notch here. Again the same, the systolic notch in pulmonary artery hypertension has been seen far more commonly in pulmonary embolism, where the obstruction happens proximal pulmonary arteries and the reflected waves are immediately reflected back. The delay is less, and then they create a notch. That is why if the notch happens early, which indicates the wave is coming earlier, so that means there is a proximal artery blockage, so that indicates a severe blockage. But this phenomena of notching of the systolic wave is less common in pulmonary artery hypertension of other causes. So guys, if you learned something new, please subscribe the channel. That would actually give us an encouragement to do more and more videos, and you would be notified as and when I publish any new one.